Thank you for joining us today for our webcast titled Managing Patients with Psoriasis and Comorbidities, Cases, Evidence, and Action Plans. I am Joel Gelfand. I'm a professor of dermatology and epidemiology at the University of Pennsylvania Perelman School of Medicine here in sunny Philadelphia. Also a part of this program is Junko Takeshita, who is an assistant professor of dermatology and epidemiology in our department here at Penn, and she will be doing some of the video overviews, and we'll see that later in the program. We'll go through the learning objectives briefly. Objective 1 is we'll describe the pathophysiological pathways underlying psoriasis and the rationale for treatment selection based on the mechanism of action of agents that target these pathways. We will identify comorbidities common in people with psoriasis and how to think about identifying these conditions and thinking about treatment selection based on these comorbidities. And finally, we will select appropriate treatments for patients with psoriasis based on disease characteristics, efficacy, and safety profiles. So let's get into the content of our talk. First, the epidemiology of psoriasis. It is a common disease, over 8 million people affected worldwide. It affects people of all ethnicities and racial backgrounds. And in the United States, actually a fair number of people have psoriasis and aren't aware of it. And we noticed from the research that we did looking at CDC data where we had pictures of patients and dermatologists looked at the pictures and said this person has psoriasis, yet the patient wasn't aware that's what their disease was caused. So there's lots of opportunity to educate patients about diseases they have in their skin and letting them understand what is going on. In terms of disease severity, most people in the general population have fairly mild disease, just about 2% or less. But roughly 20% of people have more moderate to severe disease that requires typically oral or systemic or phototherapy-like treatments. I think these statistics are helpful to know about because my patients often want to know, Dr. Gelfand, how bad is my psoriasis? And when I tell them, 8 million people in the United States have psoriasis, 125 million people worldwide, that information helps people feel less alone with their disease. They realize a lot of people are dealing with this, and it helps put in perspective where they are in terms of the continuum of dealing with this condition. The pathophysiology is that of chronic inflammation, upregulation of the Th1 and especially the Th17 pathway, which is associated with increased markers of systemic inflammation in some patients, such as C-reactive protein. Epidermal hyperproliferation, and I believe this is helpful to teach patients about. Typical keratinocyte takes about 30 days to be born. In psoriasis, that occurs in about a day or two, and so it gives patients insight into why they're having so much flaking and scale and epidermal turnover. The third component is angiogenesis. You see these dilated capillary loops in the papillary dermis. This is responsible for the Auspitz sign. That's why patients' psoriasis bleeds so easily when they pick at it. And finally, there is genetic susceptibility. If we think about the pathophysiology of psoriasis, it then allows us to think about rational treatment targets. So on the left side of your screen is showing the keratinocytes and certain antigens they present, either keratinocyte-derived or melanocyte-derived, that we believe are what causes the inflammatory autoreactivity in this disease. That induces an innate immune response and ultimately an adaptive immune response. And upstream of this, you have nonspecific cytokines such as TNF-alpha. This promotes the inflammatory process. You then have IL-23, which helps promote differentiation and development of Th17 cells, where their master cytokine is in the interleukin-17 family, which tends to act directly on the epidermis and neutrophils. So, of course, we know we have the TNF inhibitors, 3 of them targeting TNF, etanercept, adalimumab, and infliximab, with more in testing for approval. We have biologics that target the IL-23, IL-12 pathway. That's ustekinumab. We have approved biologics that target just IL-23. That would be guselkumab. And this is a fascinating development. At the time that ustekinumab was developed, there was a lot of debate about whether or not you needed to block IL-12 or IL-23. It wasn't clear which cytokine was critical to this disease state. So ustekinumab blocks P40, a shared subunit of IL-12 and IL-23 cytokines, and therefore blocks both cytokines. Guselkumab is more specific, blocks P19, therefore only targets IL-23. And as we'll see later in the program, that is a highly effective treatment strategy. Coming further downstream, we have the IL-23 pathway, ixekizumab and secukinumab, both block the cytokine interleukin-17A. If we move along, we have brodalumab, which is a receptor blocker. So with brodalumab, it's actually blocking the IL-17 family, things like IL-17F and A as well, affecting more IL-17 ways of increasing the autoinflammatory process. We also have several other IL-23 antibodies in development, tildrakizumab and risankizumab, and we'll see some data about that later in the program. Speak a little bit about the psoriasis comorbidity paradigm. And so when you look at this slide, really the question is, how does this disease, psoriasis in the middle, relate to this disease in the right of screen, cardiovascular disease? Because phenotypically, they seem so different from one another. And it turns out that these two conditions share environmental risk factors, smoking and obesity, for example, and actually have some overlapping genetic susceptibility loci. Then when you have psoriasis, you're subject to the pathophysiology of the disease. We know that chronic inflammation, epidermal proliferation, and angiogenesis, all parts of the pathophysiology of psoriasis that also overlap with the pathophysiology of atherosclerosis and thrombosis. There are treatments we use, some of which may increase cardiovascular risk, say by increasing secondary risk factors like, say, cyclosporin causing hypertension, and then some therapies which may be cardioprotective through their anti-inflammatory properties. We'll talk more about that later. And then the burden of the disease in terms of comorbid depression, alcohol use, smoking, even lower socioeconomic status. All these factors may combine to promote cardiovascular disease in our patients. And as the research has evolved, we really realize that this is actually a systemic disease. It's not just a disease of the skin, and I will show you that in a few moments as we go through some of the comorbidity outcomes we see in these patients. So what's well established at this point in time is cardiometabolic disease, major cardiovascular events, heart attack, stroke, cardiovascular death, metabolic syndrome, obesity, insulin resistance, and diabetes, of course, psoriatic arthritis, mood disorders like anxiety, depression, and suicide, Crohn's disease, and of course T-cell lymphoma of the skin, which is rare, but we as dermatologists really need to be at the front lines of picking that up. And some of our therapies can exacerbate T-cell lymphomas and cause progression, so we don't want to miss that diagnosis. This is a summary slide of the first sort of 10 years of the research I've done in this field. And what you'll see is first the mortality curve here. You'll see that the curve in black is people with psoriasis receiving systemic phototherapy, so typical patients that we may see in dermatology practice. And their mortality curve is shifted to the left. They die about 5 years younger than they should based on the age-appropriate risk factors for mortality. And then if we look at the table below, we see a dose response, smaller associations for major cardiovascular events compared to those with more severe psoriasis, again, based on the treatment patterns people are receiving. So someone who's only treated topically, we think probably has mild disease. People getting phototherapy or systemics, we think have more severe disease, and you see much higher rates of things like major cardiovascular events or diabetes or chronic kidney disease. And this is all independent of traditional risk factors. So in these analyses, we are controlling for people's, say, blood pressure or their cholesterol or their smoking status or their BMI, and still see these kinds of associations. This risk is pretty substantial. The risk of cardiovascular disease conferred by psoriasis when it's moderate to severe is similar to diabetes, and I mentioned earlier that it culminates in about 5 years of life lost. More recently, we published some data showing that if a patient has 10% more body surface area, they have about an 80% higher risk of mortality over the preceding 4 years, independent of risk factors. It's a large study we did looking at about 9,000 patients. And one of the important things to do with this information is know that we should be screening patients for cardiovascular risk factors, or at least educating them about the risk of cardiovascular disease and referring them back to their primary doctor for age-appropriate screening, things like blood pressure checks, diabetes screening, lipid checks. Because we know if we do this, we could potentially improve their health outcomes by lowering the risk of cardiovascular disease, the most likely thing to cause premature mortality. Unfortunately, we're not doing a great job with this. This slide shows the odds of having poorly controlled hypertension based on your body surface area, and as you can see, as the histograms go up, that means your body surface area is going up, and the odds of having the blood pressure adequately controlled based on guidelines is declining. And this is a large population-based study in the United Kingdom where they are heavily incentivized to control blood pressure. And again, we're controlling for all the risk factors for blood pressure control, body weight, and the regimens that they're taking. A recent study, also out of the UK, found that 37% of newly screened psoriasis patients were found to be at high risk for cardiovascular disease 46% had suboptimal cardiovascular risk factor management, so fairly similar to what we found before. So this is really eye-opening. It tells us that if we look, we are likely to find pathology or risk factors that can be intervened on in a way that could lead to better outcomes for our patients. A key question that we're grappling with is whether or not treatment of psoriasis will lower the risk of cardiovascular events and mortality. This is a meta-analysis from the rheumatology field, multiple studies looking at the impact of methotrexate, TNF inhibitors, on cardiovascular events. This data does also include some psoriasis studies, and similar studies have been published in the psoriasis field, just not to the large volume that we have in RA. And if we look at the bottom line here, MACE events, those on TNF inhibitors are about 70% less likely to go on to have a major cardiovascular event compared to patients with these diseases treated with other approaches. Methotrexate also looked like it was cardioprotective of MACE events, although in this case it wasn't statistically significant in this particular analysis. This has led us to launch a major research program where we are looking at the impact of our different treatments in a rigorous, randomized, placebo-controlled manner. So, of course, the challenge of the data I previously showed you is that it's observational data. We can't be certain that the protective effects we are seeing is related to treatment versus other factors that we can't control for. So it's hard to establish causality in an observational study, although certainly those data are encouraging. So now we're trying to do these randomized controlled trials. And what we're looking at is the impact of our treatments on aortic inflammation. This sort of PET CT scan, the bottom left side of your screen. We can infuse radiolabeled glucose through an IV. It gets selectively taken up by CD68 positive macrophages. In this case, we're showing it in the aorta. We know that degree of signal is prognostic of future cardiovascular events. We know from other research we've done that people with psoriasis have increased aortic inflammation compared to people without psoriasis, and that inflammation increases as their body surface area or PASI increases, the severity of their skin disease. We also know from other lines of research that if we lower aortic inflammation, say with statins, for example, that will rapidly lower aortic inflammation in a period of 4 to 12 weeks. So it's a nice surrogate marker for looking at the effects, the cardiovascular effects of therapies. So we have 4 trials that are ongoing. One looked at adalimumab or phototherapy. One is ustekinumab. One is secukinumab, and an open-label trial, Premolast. You should also be aware of the CERT trial. This is a major study ongoing by NIH, where they're looking at the ability of methotrexate to lower the risk of major cardiovascular events. This is an outcome study, placebo-controlled. These patients don't have psoriasis or RA. They just have a history of MI or diabetes, and so they're at high risk of future cardiovascular disease. When this study reads out, it will definitively ask the question if at least one of our therapies, methotrexate, causally lowers the risk of cardiovascular disease, and that would surely change the risk-benefit profile of that drug if we knew that not only it could treat psoriasis, but lower the risk of cardiovascular events and mortality over time. That may outweigh some of the potential side effects that we worry about as dermatologists with that medication. Talk about some other comorbidities, psoriatic arthritis and psoriasis. We know as dermatologists is a fairly prevalent disease in our patient population. The more skin involvement people have, the higher the prevalence of psoriasis will occur. So roughly the prevalence in most dermatology settings is about 20% of patients will have psoriatic arthritis. Interestingly, a nicely done study by Phil Meese showed that about 10% of people with psoriasis seen by dermatologists had undiagnosed psoriatic arthritis when then seen by a rheumatologist. And these were good dermatologists who were actually used to picking up this disease. So it could show you how challenging it is to pick up the psoriatic arthritis diagnosis in our routine clinical practice. It's important for us to be aware of that psoriatic arthritis usually comes on or after the onset of psoriasis, so we are really in the position for the ones to identify this disease first. So I educate all my patients what to look out for and to come to me if they're developing new joint symptoms. And this is because psoriatic arthritis may be progressive and can cause permanent irreversible joint damage. So with psoriasis, the disease has not scarred the skin. As far as we know, although this needs to be determined, if we don't treat psoriasis, it's not necessarily going to be progressive, although it may be, we just don't know. But in psoriatic arthritis, it has a much higher likelihood of going from being fairly mild from 1 to 2 joints to becoming polyarthralgia and ultimately resulting in joint damage. In clinic, a simple thing to do is to measure a C-reactive protein in the blood and figure out how many joints are involved in terms of the patient's symptoms. Those are both markers of risk of progression. And so if you're struggling with whether or not the patient needs to see a rheumatologist, a patient who has multiple joints involved, elevated CRP, these are people who are likely to progress, and we really have to make sure they're going to be seen by rheumatology. It's actually not so difficult to evaluate for joint symptoms in clinical practice. What I ask my patients about is, are they having stiffness and swelling or pain in their joints in the morning? Does that joint pain get better with activity? Examination, I'm looking visually for swollen joints or dactylitis, like a sausage digit, or enthesitis, the third picture on the bottom of your screen from your right, swelling where a tendon inserts. And on the right side of the screen, the higher picture, that's my thumb. Thumb is famous now, I guess. And what I'm doing is I'm pressing hard enough on my patient's joint to elicit the top third of my thumb to turn white. That is the proper amount of pressure to apply to elicit tenderness if the patient is going to be having inflammatory joint pain. I do that for all the MCPs, PIPs, and DIPs. It's very easy to do. And if many joints are tender, I may also press on the soft part of the forearm. That is tender. That is a sign that maybe this is more of an issue of fibromyalgia. And of course, I'm doing all this because I'm trying to prevent my patient from ending up like this person here, showing his elbow with these damaged, destructed joints. If I feel like the patient may have psoriatic arthritis based on my physical examination and history taking, I will order a C-reactive protein, a SED rate. I do order a rheumatoid factor and a CCP antibody. That's more specific for rheumatoid arthritis. And finally, I order a uric acid. Because a differential diagnosis, of course, includes rheumatoid arthritis. Gout could present this way as well for an inflammatory arthritis. And you don't want to miss rheumatoid arthritis. I have had a handful of patients in my practice where I thought I was dealing with PSA and I was really dealing with rheumatoid arthritis, and those patients really need to be seen by rheumatology. They have a different natural history. If they have a lot of symptoms of their hands or feet, I will order x-rays of those joints as well. There are also a lot of emerging comorbidities in psoriasis. Fatty liver disease is an important one. COPD, which one would think, well, why would that be? But actually, psoriasis, its key regulator is IL-17, which is an important regulator for pulmonary parenchyma. Adverse infectious disease outcomes, chronic and end-stage renal disease, and even sleep apnea and peptic ulcer disease. So the more we study, the more we learn about the condition. All right, so we're going to listen to a video now. That was a really great clinical encounter. It only took about 7 minutes, and Dr. Takeshita covered a lot of ground with that patient. There's a couple of learning pearls there. This concept of patients losing response to therapy over time is very prevalent, especially with biologics. Important to keep that in mind, and therefore we need multiple options, multiple pathways to manage this disease over the long haul. You saw that Takeshita talked to the patient, screening her for psoriatic arthritis symptoms, talking to her about risk of major comorbidities, discussing treatment options, and then telling the patient, I'm going to give you information, think about it, and then we'll talk more, answer your questions, and make a decision. It can be pretty overwhelming for a patient to be provided all this information at once and then be asked to make a choice right in the spot. And so usually what I'm trying to do is educate them about their disease and then go through their treatment options with them, and then finally I print out information for them to read and think about, and then we come to a decision either by the patient calling me back or sending me a message in our electronic medical record portal. We have a question and answer period now. We actually have a lot of questions coming in, so I'm going to try and handle these as best I can. One question is around the genetics of psoriasis, and I'll just expand on this. There are over 60 genes involved in psoriasis susceptibility currently to date. This is a advanced concept that actually men are more likely to pass on psoriasis than women, though clinically I don't really make that differentiation for my patients. It's a nuanced issue. It's probably not necessary to talk about. What I do let them know is that they have psoriasis. Their children have about a 15% lifetime risk of developing psoriasis. And I mentioned that things like maintaining a healthy body weight and avoiding smoking are some things we think we could do to lower the risk of developing psoriasis in the future. I also note to them that actually about 60% of people have no family history of psoriasis, and that's important to tell patients because for many people, they're wondering, well, why am I the only one in my family who has psoriasis? And if they understand genetics, it'll make more sense to them. There's questions about psoriatic arthritis. How do you screen for it? What areas of the skin portend psoriatic arthritis? So here, interestingly, studies suggest that, of course, nail disease is associated with psoriatic arthritis, but actually intragluteal cleft fold and scalp psoriasis seems to be more associated with symptoms of psoriatic arthritis than other anatomic locations. I personally don't recommend any of the standard screening tools that have been developed because they all have challenges in their accuracy and implementation. I think it's simple enough to ask the patient the question, do you have any joint pain, swelling, or stiffness? If they say yes, you want to differentiate, is it worse in the morning, better with activity, worse with activity? If it's worse with activity, mainly at the end of the day, that is more like osteoarthritis. It's less concerning. If it's more in the morning and less in the afternoon, better with activity, that sounds more like inflammatory arthritis, psoriatic arthritis. That then buys them a laboratory workup, like I mentioned earlier, and potentially referring them to rheumatology, depending on your index of suspicion. And so I showed before, if they have elevated CRPs, they have multiple joints involved, those are people who have a high risk of progressing. Those are people I'll be pushing very hard on to see a rheumatologist. If they have evidence of erosions, if I get x-rays of the hands and feet, that those are very much involved with the symptoms, those people have a high risk of progressing. I will be pushing on them pretty hard to see a rheumatologist. And oftentimes the rheumatologists, want to see these patients, especially if they have objective markers that have already been drawn. All right, there's a question about how do you choose a target? Is it better to choose one that targets only one cytokine? Would that produce less side effects? And I think, scientifically that is the hypothesis. For example, we would think that blocking only IL-23 would be safer than blocking IL-12 and 23. So guselkumab compared to, say, ustekinumab as a strategy. But amazingly, the strategy of blocking IL-12 and 23 is proven to be a fairly safe strategy. Large observational studies show fairly low rates of significant complications related to that. So at this point in time, although we believe it would probably be safer to block only one cytokine, we don't really have ideal head-to-head empiric type data to prove this concept. The question here is that many patients have disorders like diabetes and cardiovascular disease. Can you talk more about the evidence regarding inflammation linkage and how does it play out when choosing a drug? So here, the idea that the type of inflammation in psoriasis is related to the type of inflammation in cardiovascular disease goes back about 20 to 30 years now. It's actually fairly well established that chronic inflammation is a key pathophysiological aspect of atherosclerosis and thrombotic complications of atherosclerosis. And many of the cytokines that are involved in psoriasis are known to be upregulated in atherosclerosis. Similarly, other inflammatory diseases that are similar to psoriasis, like rheumatoid arthritis, have higher rates of cardiovascular disease. And recently, there was a seminal paper that came out in the New England Journal of Medicine called the Cantos trial. And this is a large 7,000 patient study, approximately randomized controlled trial of a biologic called canakinumab that blocks interleukin-1 beta. And what they showed in the study is that by blocking interleukin-1 beta, they had no effect whatsoever on cardiovascular risk factors, didn't affect their triglycerides or their cholesterol, but their C-reactive proteins went down, and they had a lower risk of major cardiovascular events compared to placebo. So that is definitive proof of concept that immune targets can lower cardiovascular risk. All right, we're going to come back to questions in the next session. We'll have some time for some more. We're going to move on to our next part of the didactics at this point in time. So I want to talk a little about PASI endpoints. You probably hear a lot about PASI 75 and PASI 90. I want to show you what this looks like so you can have a sense in your mind of what these endpoints mean. So here's a patient, typical patient in a phase 3 psoriasis program. PASI at baseline is 25. In this trial, at week 4, they hit a PASI 75. This used to be our gold standard. It's considered to be a very good response. But you can see this patient still has a fair amount of disease activity in the arms and the abdomen. PASI 90 is pretty close to being clear, almost clear. You see subtle residual lesions for this patient. PASI 90 increasingly is becoming the target we are trying to hit. And let's look at what these response rates look like. So we look at our existing therapies as well as some therapies that we've let go of over the years, either for safety or efficacy reasons. We see for PASI 75, as we go from left to right across the stream, we see higher and higher rates of achieving these endpoints. Our commonly used oral medications like methotrexate and apremilast have PASI 75 rates around in the low 30s to mid 30s, whereas some of our newer therapies like targeting IL-17 or IL-23, roughly 80% of patients or 85% of patients achieving PASI 75s. We look at the PASI 90 endpoint, an even higher bar efficacy, even greater benefit for the patient in terms of their experience of disease. We see that roughly 60 to 70% of patients are achieving that with IL-17 inhibitors and the IL-23 inhibitor guselkumab. Also shown on this slide is something called the number needed to treat. What this means is how many patients do I need to treat with this drug to achieve one extra response over placebo. So in this case, this slide would tell me that if I want to use apremilast and I want to achieve PASI 90, I need to treat about 14 patients to have one person hit a PASI 90 compared to if I just gave them placebo. And so that's a pretty high number needed to treat. The goal is to achieve PASI 90, clear, almost clear, unlikely to achieve that with those type of agents. Whereas when we look at the newer MOAs, the IL-17s and guselkumab, you have NNTs that are in the high 1.8s to mid 1s, remarkable levels of efficacy. And still, some of our older therapies like adalimumab and ustekinumab seem to be able to achieve these targets as well, but maybe potentially slightly less commonly than some of our newer therapies. Does it matter to achieve a higher clearance of skin disease? Well, this is a study we did several years back in my research network called the Dermatology Clinical Effectiveness Research Network. This is a series of dermatology sites across the country where we collected data on our patients consecutively over a year period of time. And we looked at their skin and their health-related quality of life using an instrument called the DLQI. This is roughly about 2,000 patients we looked at over a period of a year. Here you're looking at the fairly small percentage of patients who actually were almost clear their disease and were on systemic therapy at the time. So showing that our odds of having clearance, at least in clinical practice, pre-IL-17 era and IL-23 era was fairly low. But in any event, what this graph is trying to show you is that for those who had clear skin disease on the day of their evaluation, virtually all those patients had minimal effect on health-related quality of life, whereas fully about 20% of patients were only almost clear. That's like a PASI 75 to PASI 90, if you will, somewhere in the middle of there. About 20% of those patients had enough impairment in health-related quality of life that guidelines would recommend we switch them to a different treatment. And so our old paradigm of being almost clear is leaving a lot of our patients not achieving the goal of where they want to be. We'll look now at some of the data comparing head-to-head clinical trials now. And this is looking at secukinumab, showing its high response rates. But the main thing I want you to take home from this slide is how rapidly the IL-17 class works. By 4 weeks, you're already having a measurable number of people, roughly 30%, if you will, hitting clear, almost clear, starting to hit their PASI 90s. And so I often bring people back rapidly while I'm using IL-17s because it's really a clinical pleasure to see a patient who had really bad disease, and in 2 to 4 weeks, they're almost clear of their skin disease. It's a remarkable experience for the patient, and I want to be there to share with them in that experience. This is now showing secukinumab data compared to ustekinumab data going out over a year. Again, both drugs achieving high response rates, but demonstrating that an IL-17 achieves even higher response rates than an IL-12/23 antibody. I'm going to go a little bit quickly now because we're getting short on time. We've got a lot of questions I want to get to. This is ixekizumab, an IL-17 inhibitor against ustekinumab. A similar story here. Both very effective drugs, but you can see you get even higher rates, and you can differentiate more when you have higher bars of efficacy like PASI 100. And again, note the rapid onset of efficacy. Week 2, you already have 20% of people with a PASI 75 on ixekizumab. It's remarkable. This is brodalumab, an IL-17 receptor inhibitor, versus ustekinumab, again, showing superior efficacy. This is guselkumab versus adalimumab. Again, adalimumab, an excellent drug with good efficacy. And look at the higher response rates, especially when we're looking at PASI 90s and PASI 100s, really differentiating its results from adalimumab. This is tildrakizumab data, an IL-23 inhibitor, comparing it to etanercept, and again showing superiority, although we know etanercept is not our most effective TNF inhibitor. It would be nice to compare this drug to, say, adalimumab or guselkumab or the IL-17 inhibitors. It's also important to recognize that these great results we're seeing in clinical trials are not always mirrored in what we would see in clinical practice. This is data, again, from my network showing the odds of being clear, almost clear, based on whatever therapy you're on. This is data from a pre-IL-17 era. And what you're seeing in the histograms is where they were that data, odds of being clear, almost clear. And then the bar lines, what we would have expected based on what's been reported from randomized controlled trials, usually phase 3 clinical trials. And a lot of what is going on here is that people lose response over time, shown by this slide. It doesn't project very well, but what you're seeing is the odds of the patient continuing on their drug over time. So survival of the drug, thank God, not survival of the patient. The patient's doing fine, but people are often losing response to their drug and coming off of it over time. So in this slide, you see that ustekinumab, shown in purple at the top of the screen, that has the best drug survival. That means that if you start with that drug, the patient is likely to persist on it for a longer period of time than some of our other treatment strategies, in this case TNF inhibitors, or even the IL-17 inhibitor shown in yellow here. This is secukinumab's persistence. Important to recognize that's a smaller number of patients there, and a lot of channeling. A lot of these patients had been heavily pretreated with other drugs before. But I think in psoriasis, we're really trying to play the long game. Our goal is to clear people's skin, do it safely, and do it over the long term. Having to switch through multiple classes of drugs, we believe, increases burden for the patient as well as through the healthcare system. This is a summary slide. Certainly, treating psoriasis requires us to look at many different factors. This is a slide you can look at after the program. It does answer some of the questions. There was one question in there related to what would you do in a patient who has Crohn's disease? And here, things like IL-23 inhibitors or adalimumab or Remicade, infliximab would be good choices. We have another video we'll go to now. So, I really love those videos with Dr. Takeshita. She really shows us, how rewarding and simple that conversation can be with the patient. The patient is looking for information about their disease, and they're looking for direction. And Dr. Takeshita really lays out in plain language what the issues are, who to follow up with, engage with their primary care doctor. It's something that could be easily fit into our usual clinical encounters with our patients. So I think it's a really nice teaching example that CME Outfitters put together for us. I'm going to go through some questions at this point in time, and we have a lot of them, which I want to thank you for. It shows great engagement. We have a question here. It says, I'm a pharmacist. I sit on the P&T. Do you know of evidence to support these treatments based on a total cost to the system and patient? We have a challenge getting approval for any treatment until they fail methotrexate. This is a great question, and we need to recognize as prescribers, as dermatologists, these therapies are quite expensive, and so they should be reserved for patients who truly need them. In terms of classic cost-effectiveness analyses proving that these therapies are more cost-effective than methotrexate, that data does not exist. And that is primarily because the strategy has been cost minimization, meaning that if the goal is to treat the disease as cheaply as possible, then methotrexate would be your strategy. If your strategy is to try and treat the disease to have the best likelihood of clearing the skin, you will have a different strategy. And so that's important to keep in mind. The other conversation I have with patients is, let's say that their plan is willing to consider biologics, they've failed methotrexate or they have contraindications to methotrexate or it's not an appropriate therapy for them. Then we go through looking again at what their comorbidities are and showing the slide here about the many factors that influence pathway selection. So my patient, and this happens, has a history of optic neuritis, a history of something that's similar to multiple sclerosis. I would not recommend a TNF inhibitor. I would say we need to move towards an IL-12 and 23 or IL-17 or IL-23 pathway. And so if they have no contraindications to any of the biologics, I'll say, you know what, it's going to depend on what your insurance company prefers as the first-line biologic. Often in my area, that's going to be adalimumab. But through my detailed medical history taking, and the patient has a contraindication, then that will steer me towards alerting the insurance company to say, well, you know what, this person had Guillain-Barré as a 20-year-old to a flu vaccine. It would not be a good idea to use a drug that could cause demyelinization like a TNF inhibitor, for example. Or let's say they have a very strong family history of Crohn's disease, or they themselves have had Crohn's disease. Let's say, we really should not be using an IL-17 inhibitor. We really need to go in this direction for this patient. And oftentimes I find the insurance companies are reasonable about that. The question here, have you had a patient reach PASI 100%? The medication was discontinued and the psoriasis did not return. So I do tell my patients this is not a curable disease. None of these therapies are expected to be remittive permanently. It's true that the IL-23 strategy seems to produce some remissions in patients. In my own clinical experience, I think that some patients, although the disease will recur, they tend not to come back as bad as they were when we started, and this is with years and years of follow-up. But that being said, the overall rule is that patients' disease will return over time. It just returns at different trajectories depending on which biologic we have chosen, which strategy we're using. Which medication combination would address both the nail and hand involvement in psoriatic arthritis? Well, here we have several classes of drugs that are FDA approved for psoriatic arthritis. Certainly TNFs have been considered a gold standard there, looking at my chart. IL-17s have been approved for psoriatic arthritis as well. Ustekinumab is FDA approved as well for that indication, although we tend to think that it's not as effective as a TNF strategy or the IL-17 strategy. So generally speaking, if they have inflammatory arthritis, we're usually in a TNF to IL-17 strategy for these patients, although clearly it can be individualized. Here's a question about diet. This comes up all the time in my clinical practice. Patients want to know, should they be eating less gluten or should they be eating more gluten? And here what I let them know is that there's a lot of fads and a lot of sort of anecdotes out there. But the reality is that there really hasn't been any definitive evidence that the diet exacerbates psoriasis. What has been clearly shown, though, is that weight exacerbates psoriasis. People who are overweight will have more severe disease, will be less likely to respond to therapy. And people who lose weight, we know this from randomized controlled trials, their psoriasis will become more mild and is likely to respond better to treatment. So when we talk about diet, I say, a heart-healthy diet, regular exercise, things that you could do to lose weight will help you in your battle with psoriasis. All right, this question is, if the rheumatologist would use the same type of medication you would use, do you just wait and see if the treatment's helpful, or do you wait for the rheumatologist's opinion first? So this is an interesting question. So when doing team management, I think of it this way. If the patient's main complaint is their skin, a disease of their skin is really bad, and their joints are kind of minor, then I think my treatment will dictate what direction we go. If their joint disease are clearly severe and their skin disease is not as bad, I'm going to defer to rheumatology probably more for what they want to do, or try and make it shared decision-making if we're somewhere in the middle, where I'll say, why don't we choose a highly effective drug for the skin and the joints, for example. That's how I think about that problem. What biologics would be the best option if the patient also has cancer? This is a complicated question and discussion to have with the patient. From a labeling point of view, the IL-17s and the IL-23s have no warnings for malignancy currently. And this is based on the fact that the drugs seem very safe in their clinical trials, and the immunology of cancer seems to suggest that these agents are less likely to get into trouble with malignancy. That being said, we don't have rigorous data of the safety and efficacy of these drugs in humans. Oftentimes what we know about biology doesn't work out when we try it in humans. So for example, TNF inhibitors were felt to work for multiple sclerosis. That's why they were tried there, and it ended up failing in that indication and actually aggravating it. So I explained to patients we have a lot of uncertainty. And I certainly have some patients who have cancer, and we choose to use IL-17s or IL-23s, and that's usually in the setting of we're trying to palliate the patient. They and their oncology team are willing to tolerate the uncertainty of using these immune-targeted therapies in that setting. Oftentimes I'm trying to use methotrexate, retinoids, phototherapy if I can, but I will use some of these more targeted biologics when I need to. We have lots of questions, and I'm looking through them. Here's a question that says, could you comment about clearance versus PASI score? They have a PASI of 90, but they still have plaques in the face and neck. That's not acceptable. I hear too many physicians tell patients they're as good as they can expect, and that's unacceptable. I agree with that statement. And so usually what I do is I talk to the patient, And I say, this is where we are today, and maybe we could do better. And the advantage of trying a different therapy is that we may get you completely clear. The disadvantage, though, of course, is that if we are switching around therapies quickly and rapidly, there's no guarantee that we're going to not lose response to some of these treatments. So I'm trying to play the long game with my patient. A patient who has already been on multiple different treatments, I am going to be a little reluctant to switch treatment early on. I want to make that therapy work as long as I can. Maybe a patient who's a little more early into their journey, I might be more willing to switch to a different therapy early on. But I do explain to them that our goal is to pick a therapy that will work long-term for them. So here's one I covered briefly before, a patient with IBD, inflammatory bowel disease, and psoriasis, sent to me for a lack of efficacy of methotrexate, recommendation of next agent, female, 35, 2 young children, no plan for more, no history of diabetes. So here, one is we could try to maximize the dosing of methotrexate. We could try subcutaneous methotrexate, although reality is I would move on quickly to therapies that treat both diseases. Usually that's going to be a TNF inhibitor, such as adalimumab or infliximab, and I would do that in combination with the GI doctor. Or we could consider ustekinumab, although the dosing there is substantially higher for Crohn's than it is for psoriasis, and there we really would want to work with the IBD doctor. We are coming to the end of our time. Our action plan, what we want to do is we want to determine the objective severity of psoriasis, as well as subjective impact on the patient's health-related quality of life. The more extensive that psoriasis is, the more burden they have, the more we should be considering treating disease to highly effective therapies. We should identify common serious comorbidities in these patients to improve their long-term health outcomes, as well as help us select the proper treatment. And of course, we ultimately use our knowledge of treatment history, comorbidities, and patient preferences to individualize treatment decisions. And I think the narratives and the questions we've gone through have really shown that. If a patient has lost response to a TNF inhibitor, or never had a good response to it in the first place, we may want to switch mechanisms of actions instead of trying the same class, for example. To receive CME credits for this activity, you should complete the post-test evaluation online and click Apply for Credit link that you'll see in the presentation slide window at the end. I want to thank you all from CME Outfitters. Thank you all for joining us today for today's presentation on psoriasis. I hope you're able to incorporate strategies into your practice and what we discussed and improve the care of your patients. And I hope you'll visit our website, www.cmeoutfitters.com, for a complete list of upcoming CME activities and archived ones. And I want to apologize for not getting to all the questions. We'll work with CME Outfitters and see there's another way for us to make sure we cover all these excellent questions that came up through the program. With that, I will thank you for your attention and for spending your time with me today.